Hello, and thank you for joining today's Lunch and Learn webcast. Our guest speaker today is Dr. Kelly Henchel, Section Chief, Pediatric Medicine, Jefferson Plaza in Franklin County. The topic today is pearls for teaching in ambulatory care. I will turn it over to Dr. Henchel.
Good afternoon, and thanks for joining us for this lunchtime topic. I'm going to talk to you today about pearls for teaching in ambulatory care. I continue to try to be an expert in this and with self-improvement every day, as this is becoming increasingly challenging for us with pressures to have rapid turnover in ambulatory care and to see an adequate number of patients, as well as participating in teaching of a good variety of learners. So first of all, I wish I had some financial disclosures. Unfortunately, I have none. So when you sit down with a group of learners, and I realize that this can be a rapid turnover as well, that you may have learners who are there for a day, for a week, for a couple of weeks, if you're very lucky, up to a month. So you are seeing a great number of people coming through, and so setting goals can be very important. And when we think about setting goals, I think it's very important to look at your goals from three different perspectives. Our patients certainly have one set of goals. It can be very satisfying for them to have learners spending time with them in the ambulatory care setting, but it can also be dissatisfying because it typically takes longer to see a patient when a learner is involved. So respecting time constraints and setting the stage for those patients coming into the clinic is very important. That stage is very important for the office staff to be involved in, so that when they are registering for their appointment for that day, the stage can be set early on that the physician is teaching today, and your appointment may take longer than it normally would. And the same goes for the scheduling stage. If they can be set that stage early on, the day that you're being scheduled for, the physician will be teaching, and this may take more time. It really helps the patient with their expectations of the visit. Then setting goals for the student really involves setting an agenda or making a learning contract so that the student is very clear what is expected of them during their time with you, as well as clearing up any misunderstandings or preconceptions that they might have from previous experiences that are not the same in your setting. And of course, as a teacher, we definitely have an agenda that we want to share with the learners, and depending on the level of the learners, that may be more set or more fluid. So it's really up to us to describe our expectations as far as what we are expecting from them. It's very important for us to tell them what we expect from them when they're presenting a patient. What should this look like to us, so that the time that we expect to spend and the time they expect to spend can be enmeshed together. It's important to sit down, discuss the expectations before you start with any learner. Oops, wrong way. So what is a learning contract? This is where students set the learning objectives with the teacher. And for us with the Virginia Tech Carilion School of Medicine, now I'm blanking, Dr. Bagtani, as the director of the medical students coming through pediatrics, really sets objectives with them on a global level, but within that they are coming to multiple different learning sites. So it's important to define what you expect at your site, what they should be getting done, and how to accomplish that most successfully. And our learning contract with the students involves the direct observation form, where the students are tasked with defining their area of feedback. Most of us have used this form and taught with it with the students. It's important not to just let them say, I would like feedback on all areas, because of course this is too difficult to accomplish in one clinical interaction. They also have a learning list, which for us is a passport, where it gives them the expectation of what they should be seeing and who they should be getting experience with throughout the course of their rotation. Formal contract setting is a little bit more advanced and typically is for our upper level learners, fourth-year medical students and residents, where we set goals together, help define the resources available to meet those goals, and then set evaluation times, including mid-rotation or end-of-week feedback, so we can make sure that we are both keeping up our end of the set goals in that formal contract. So what that might look like is somebody would like to have mastery of pediatric asthma while they're rotating with the pulmonologists. And as this goal would be set, that would include the pulmonologists giving them the resources that are most applicable to that task, and then making sure that those resources have indeed been used, explored, and taken advantage of, and then setting time for feedback with those learners. Well, if I could go the right way just once. So teaching styles. There's two teaching styles that are written about in most of the literature on teaching in ambulatory care. The first is the learner premise. The learner premise is where assessment is made of the specific needs of the learner, and then the teaching follows for that learner's level. This is where we typically function with the residents and fourth-year medical students where they have already covered the basics, and we're trying to assess where they actually need to be advanced and where we can most help them in our short times with them. So that works very well where we're looking at what that learner's goals are. We agree with their assessment of their goals, that it's meshed in, and we make a plan. The teacher premise is where we have developed a set agenda for our teaching points. This works very well with the novice learners or third-year medical students and tends to be quicker because we have practiced that agenda very frequently. So this is important with those younger learners who they might not have the basis to know what their to be able to make an assessment of where their strengths and weaknesses are because they are really just getting down to basics. So what are the components of teaching that we do every day? Many of these are subconscious where we're not planning, well, I'm going to tell you, ask you, or show you to do something, but in fact being aware of what these are can help make you a stronger teacher. So when we're telling, this can be in many different forms. With directive telling, we're using descriptions. We're using free value, specific, well-timed, and brief feedback with our learners. It's really important when you're giving feedback that you tell them what they've done well and try to be positive, avoiding things like you didn't do it. Replace it with, I do it this way because. So being positive with, this was well done, you did a good job, I do it this way, rather than, but you didn't do, really helps make this a positive learning experience. Comparison learning, of course, is where you're referring to outside authorities. So this is where you've had a student, let's say, who tells you what their plan is for a pediatric infant with hip dysplasia concerns. Maybe this was a breech baby. And they tell you what their plan is, and instead of being authoritarian and telling them, well, that's not the way it's done, this is the way I do it, this is a very easy place to refer them to the outside source, like the American Academy of Pediatrics guidelines on hip dysplasia. So allowing them to go to the expert source gives them somewhat less anxiety with the physicians being automatic authorities, but showing that there is authority beyond us. So that sometimes will ease anxiety with learners who are anxious about doing the right thing for the physician rather than understanding that these are actually guidelines that we're comparing our practices to. Response telling is where you recognize the teaching point and educate. This is where it can become very tricky in our very busy clinical settings because there's, of course, a 30-minute, 40-minute, or 50-minute presentation we can give on many points. But we are very limited in time, so it's really important to try to make this a brief and concise teaching point. So this is in response to something that the learner has told you that was incorrect or not quite right, and you want to make a brief and concise teaching point. Check to make sure that this is clear, and do they have questions. And a good way to do that is to have them tell you what you've just told them. This is also a point where you can tell them that we can come back to this with more teaching when there's a time where we can make that happen. Asking is your classic Socratic technique for teaching. And when you're using that method, you're using general to specific questioning, where you start with what is the problem, how can it be treated, exploring what does the learner already know about this, and then moving on to what else is there, and then having them help you narrow down the differential. This guides the learner to the teaching point, but this does require a lot of time in a time-pressured environment. Another way to accomplish this a little bit more quickly is to use questions that are very specific from the beginning. What do you know about the condition? What is the most likely diagnosis? Now tell me how your history fits this or does not fit this, and then let's go over the physical exam together to see what is confirmed with that. So this would be inquiry. Readiness is assessing the level of readiness for the next learning point. I think what we really need to understand there is that everybody is not ready for the same level of understanding, and by using the asking prior, you can assess what they're ready for to continue learning along that. It may be just a simple point. They may be ready for the whole topic. So assessing readiness through your questioning is important. And again, those can be tabled till there's more time to spend with the learner. Showing. I think showing is one of the things that sometimes gets overlooked by our upper level learners. I think because they assume that, oh, we're all doing the same thing in the exam room, which is really not an appropriate assumption. It's, of course, demonstration for motor skills, tasks like venipunctures, lumbar punctures, and other mechanical things. But I think that teaching the effective skills through demonstration, how do you deal with a difficult situation? How do you deal with a parent who does not want to vaccinate their child? How do you navigate through these difficult conversations is really one of the areas where even the upper level learners can learn through us demonstrating. So that's part of the role modeling, and role modeling is such an important part. We're so tasked with the learners seeing everything we do, right down to what is our intellectual curiosity? How many times are we looking up, looking for a better answer, rechecking answers that we've believed for many years, and showing them that this is part of being a continuous learner. Critical analysis. When we're looking back at our own practice styles, performing quality improvement in our offices, showing them that this is still an important part, and we can role model that. It's almost a subconscious thing that we're doing as they're seeing patients with us. How to demonstrate compassion, how to get along in your interprofessional relationships throughout your offices and the system in general, and demonstrating to them what our work-life balance looks like and how to improve that if that is not going well. So there's so much that can be done in showing, and most of this I really feel like is on a subconscious level, but I'm a big fan of even having your upper level residents come in and watch you with some of the conversations that are difficult, because this demonstration is very important. Timing. Timing is the number one most difficult thing we deal with in teaching in ambulatory care. So you're really looking for places where you can teach in a more complete manner than when you have patient after patient scheduled throughout the day. So one of the most important times is before patient care begins, making sure that you're getting anything that was left over from the day prior, or if you know that there's something coming up in that day that really needs to have some attention for teaching, to take that time to do so. And on that note, it's very important that when the first patient is ready, that you yourself go in to see that first patient with your learners, because if you're waiting for that learner to come and go, you've set yourself back 15 to 30 minutes before you've ever started out your day. So before that first patient comes in, but make yourself present for the first patient care. Teaching between patients is that really difficult brief time, but if you have a no-show in your practice, and that now is going to give you some extra time, definitely a great time to take advantage. And then over lunch break, assuming that you're getting a lunch break between patients, sometimes we run through, which then means that any of those things that they really felt like they didn't understand or needed to be made more clear, after patient care time is a good time to talk about those. So remembering to ask the learners at the end of the day, was there anything we did today that was confusing, didn't make sense, that we need to be more clear on? That doesn't necessarily mean you need to now spend the next 2 hours, and sometimes it's very appropriate to assign topics for them to investigate on their own. But making sure that that's clear at the end of the day is very important for that learning opportunity. So during patient care, of course, you have this very limited time. So what you're typically modeling is case discussion, which gives you only 5 to 10 minutes best case scenario to discuss the patient with the learner. So it's really encouraged to keep a list of the teachable points for those possible downtimes, lunch or after patient care, or if there's a no-show, that you want to go back and cover with the learners. The most difficult thing I find in teaching is resisting that urge to cover everything you want about a topic between patients, because this, of course, over the course of the day can set you back hours and lead to patient dissatisfaction. So being careful to resist that urge, table things that you can until later in the day or even the next day is important. One of the really nice acronyms that I ran across was using SNAPs to help you be brief in your patient care time teaching. And the S is for summarizing, making sure that the presentation is brief of the history and findings rather than overly stated to give you time. Now, of course, with your early learning, like third-year medical students, there are many times where you need to make that less brief, and this may not work so well. But for your upper learners, once you have a feeling of where they actually are, you can have them more briefly summarize their history and findings. Then N is for narrow. Let them bring it down to 2 or 3 relevant diagnoses. Of course, many a times those the differential can contain many, many more than that, but narrowing it down to 2 to 3 diagnoses that you would like to spend time talking about is important. Then A for analyze. Compare and contrast the diagnostic options with them quickly. And then P for probing. Ask them the specific questions in areas of uncertainty which are concerning for that particular case. And then the second P is the plan. State the suggested management plan. And then S is choose an issue or topic that the case, specific to that case, that would allow for additional reading and learning for that learner on their own time. So guiding the learning based on the patients that they're seeing. And then, of course, using direct observation, whether it be live or by video, is important to see what's actually happening in the exam room with that learner and better defining what level they're actually on. This can, of course, be accomplished by live direct observation or by video observation of the learner in the exam room. The live observation gives a little bit less opportunity to critique that learning because it is, number one, in front of the patient, and you need to be careful not to make that embarrassing for the learner, while video allows you more time because it can be done after patient care and a better chance to be a little bit more critical of things that you might see. So both offer good options. Everyone's favorite, the chart. Of course, the charts can also be used for learning outside of patient care time. So chart reviewing before a visit to be prepped for that patient care is an important learning event for students and for residents and for us even. And then using stimulated chart review, where we go through a chart in a stepwise fashion, look for the whys, the what-fors, and explore the decision-making that happened over time for a patient is a really powerful tool for reviewing the decision-making skills. It also can help with efficiency as those skills have become more solidified over time from exploring through this method. Then criterion chart review is really where you go back at a later time, sit down, review with the learner what happened during these visits. Did it follow guidelines, and were things done appropriately or not? So this is one of the things that I know in staffing with a continuity clinic where those residents are seeing patients more independently, making sure to review them, make sure that the criteria or expected care was given, and then making sure to double back and review that with the learner is done. Also very powerful in teaching and solidifying their care choices. So all of this sounds really great, but again, we're on this very tight schedule, and this requires a big commitment. I think one of the things that is very helpful for us in the teaching realm as well as for the learners is it's very difficult to learn multiple things at any point. So picking one small change or one of these small suggestions for helping you manage learners in the busy ambulatory care clinic can take you a long way. Now, if you're still really time-bound, I think the 1-minute preceptor, which we have heard a lot about in recent time, is a really good way to help in the most busy clinical settings. So this is getting a commitment, probing for supporting evidence, teaching general rules, reinforcing what was right, and then correcting mistakes, being, again, very sensitive to next time try this instead or do it this way because making it a more gentle correction than you didn't do this right. So I have a very entertaining version of the 1-minute preceptor that helped me remember what was actually going on during that time. So I'd like to share that with you. This was made not by me, found through a lovely YouTube search on the 1-minute preceptor, and I found it sort of said a lot of the things that none of us want to say out loud about having to work in precepting in a very busy environment. So we'll give this a try and see how it comes out.
Recording. It only takes my student about a minute to present a case. What? How does that work? I just use 1-minute preceptor. 1 minute what? It's one of my teaching tricks. It's easy, it's fast, and it makes me look so smooth. You gotta give it to me, dude. I'm dying here. Okay, but you're buying lunch, right? Okay, but this better be good, and I'm not supersizing you. Helio. Okay, hit me. Seriously, I have to get back to the clinic toot sweet. Right, so, you know the way normally the student comes out and they try to present the case to you like, yada, 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 presenting complaint, blah, 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 medical and surgical history, medications, allergies, whatever. Oh, yeah, I'm very familiar with all that. Good, because the first thing you gotta do is skip over all that crap. Really? Yeah, just kick it to the curb. Students are supposed to have learned that before they get here. So just skip over that and get to the good stuff. Are we allowed to do that? For sure. We're not forgetting about all that stuff. We're just saving some time. That's what the 1-minute preceptor is all about. Okay. So what do you do instead? Don't worry, man. We got steps.
Step 1 is get a commitment.
Whoa. Boundaries. I'm pretty sure we're not allowed to do that with the students anymore.
Oh, no, not that sort of commitment. You just need them to commit to a diagnosis.
You just, ask them straight up? Okay, so what's the diagnosis?
Well, I usually say it like, what do you think is going on, or what do you think we should do?
But what if they're wrong?
Doesn't really matter. You just got to get them to make a decision.
Okay, I think I can do that. What's next? Clock's ticking, dude.
Okay, step 2 is probe for supporting evidence.
Ha! Probing the students, eh?
You really have some issues, don't you?
Yes.
Well, look, you're just asking them to explain their reasoning here. Okay, you think the diagnosis is whatever. Tell me why. If they got the right diagnosis, you want to make sure they got there the right way. And if they're on the wrong track, you need to know where they went wrong. This is the longest step. It can take 30 seconds maybe.
That's half a minute, bro. We better speed it up.
Just focus on the important stuff here, positive findings and relevant negatives. It's pretty quick. At this point, you might go and see the patient together briefly and confirm what your student has found, and make a plan.
Okay, what's next?
We're almost done, and the next 2 steps are linked. Step 3 is reinforce what was done well. Pick 1 or 2 things the student did right and let them know they did well.
I love getting positive feedback. It gives me all those warm fuzzies.
Okay, but keep it brief, because step 4 is give guidance about errors and omissions.
Can we just skip that step? I really need my students to like me, dude.
Nope, you've got to help them learn, which means telling them when they screw up.
But what if there's 6 things they screwed up?
Just pick 1 thing. Tell them and move on. Remember, you only have a minute.
Okay, I think I can do that. Just breathe. Is our minute almost up?
Almost. Step 5 is teach a general principle. For each case you see with a student, give them 1 pearl. Like a general point that applies to most cases.
Cool, a teachable moment don't mess with the pancreas.
Something like that, or always check for hernias on the abdominal exam. Make sure to check the lipase for every acute abdomen.
Okay, I can do that.
That's it, we're done. Next patient, please.
Really? That was never a minute. That was so fast.
It is fast. But remember, you should do this every time a student sees a patient for you, and get them to make notes. At the end of the clinic, you can sit down and review all the stuff they learned today. They should have at least 1 thing for each patient they saw. They learned lots of stuff, and you look great. It's a win-win.
And I'm all about looking good.
Yeah? Yes, you are. Now, before you go back to clinic, can you remember the steps?
Okay, let's see. 1, get a commitment.
Put a ring on it.
2, probe for evidence.
No actual probing.
3, reinforce the good stuff.
Not too much.
4, guidance on stuff that could be better.
Just 1 thing.
And 5, teach a general rule. And then move on to the next patient. Clinic's going to be so lit from now on.
So I hope that was entertaining to you and will help solidify what a 1-minute precepting task can look like. I think that the most important part for me, and probably the most difficult, is making sure to give the guidance feedback, the omissions, so that you can help them build rather than just continuing to tell them, oh, you did great, you did great, you did great. So making sure that you frame that constructive point and getting that into your 1 minute is really important. Allowing for that teachable moment to be brief, letting them take notes, and writing down what they've learned today really helps with every learner to say, well, I really did learn something today, that rather than just, whew, we were swamped in clinic. So hopefully this will be a little bit helpful in some way in your teaching in your ambulatory that were surprisingly old, that were very, very great in reading and refreshing how to be an effective teacher. Both were still available over the internet, and I would like to thank Paul Dallas, who turned me on to these wonderful references, and those are both here. And then, of course, there are internet galore articles on teaching, but these books are fabulous, and I'm happy to have them in my collection. And again, no financial interest, but they're worth putting on your bookshelf. So hopefully you've learned a little bit about teaching in the ambulatory care setting today, and you can put some of this to practice this afternoon.